We can't do this alone, as I've already said. So this will be about us coming together today, and that's what today is about. You're all in this room because you're part of the solution. So today is going to be a very important day, and we're going to come out with solutions. Because having spent time with Secretary Bob, I know that that's what he looks for. Not just a day where we all talk to each other and blow hot air around a room. That's the old Washington. This is the new Washington. And things will come from today, and we urge you to take them and move out into your communities and take action. Because in the end, there has to be a message of hope. And I spend so much time talking about hope, especially in medical settings when I talk to nursing groups or physicians or annual meetings or go to rehab hospitals and speak. In the absence of hope, you have nothing. And when you remove hope from the caregiver and the patient, then what ability do we have to get our feet on the floor every morning and go into that ICU or that hospital room or that rehab therapy area and help that person recover? So the ability to hope is the thing we must cling to, and we must be able to give wings to everyone in this community, because without it, we don't have a chance. Because without that oxygen, the caregiver, who is such a critical part of this equation, as Senator Dole knows, is unable to help that person or that veteran or that young man or woman who is feeling hopeless at that very moment and contemplating things that are truly unthinkable. So with that, I'd like to now invite Dr. Robert Bozart and Dr. Caitlin Thompson from the VA to discuss the scope of the issue and the work that the VA has been doing in suicide prevention and our call to action. Dr. Robert Bozart is the VA's Director of Epidemiology Program within the Post-Deployment Health Services. He has extensive experience with suicide prevention in previous positions in the department and has worked closely with the National Center on Homelessness Among Veterans to understand the associations between housing instability, use of VA services, and mental health. And Dr. Caitlin Thompson is a licensed clinical psychologist and is the Department of Veterans Affairs National Mental Health Director. Thank goodness they did this in 26-point type, by the way, so I don't have to wear my ugly reading glasses, and I'm still messing it up. And community engagement, that's a long title, but you deserve that. And in this position, she's responsible for policy development, provider and patient education in the areas of suicide awareness and prevention, implementing assessment and treatment strategies, and the dissemination of new findings in the area of suicide throughout the VA system and the broader community. So please join me in welcoming both Dr. Bozart and Dr. Thompson.
Good morning. I get the pleasure of starting for the two of us, which is my honor. I'll start by saying I have terrible handwriting. Mrs. McDougall was my third grade teacher, and she was the first to recognize that I had terrible handwriting. She would keep me after class to try to do exercises to improve that. Like most of my teachers, Mrs. McDougall was a lot smarter than I am. She knew that a good foundation in the elements of communication was going to assist me as I moved forward, and she helped me try to gather that. In many of the same ways, what we have been doing in the Department of Veterans Affairs to try to understand and contribute to suicide prevention has followed that path of development. And we know that many of the steps we've taken are generational investments in a future where we're able to contribute in a meaningful way to suicide prevention using the information we've gained. In 2006, VA started searching data from the National Death Index to understand rates of suicide among patients who receive care from the Department of Veterans Affairs. In 2008, we added to that information by collecting suicide behavior report information on anyone with a recognized suicide attempt or serious suicide ideation in VA. And over the past several years, that effort has continued to expand, and the knowledge we've gained has been tremendous. In 2012, we released our first suicide data report. In that report, as Dr. Shulkin mentioned, we estimated that 22 veterans a day die from suicide. That estimate was important for a number of reasons. Most importantly, it illustrated the scope of the problem. Up until that point, we had known really only about suicide among veterans who receive care from VA. It was the first time that we had estimated the larger population burden of suicide among all veterans. It was also important because it validated a previous estimate based on data from the Centers for Disease Control and showed that other information could be used to reinforce those previous numbers. But perhaps the most important part was that it showed collaboration in this effort, collaboration between CDC, collaboration between VA and the 21 states who provided us with that data initially to try to understand and contribute to suicide prevention activities to try to preserve life among our veterans. We learned a lot from that first report. In addition to understanding the burden of suicide among all veterans, we learned that about 70% of all veteran suicides occur among those aged 50 years and older. We learned that the highest rates of non-fatal suicide behaviors are among those between 18 and 39 years of age, 18 and 29 years of age, both among men and women. We learned that many of the people who have a suicide attempt touch our healthcare system within a short period around that suicide attempt, providing opportunities for continued assessment and intervention. We learned that service use following referral from the Veterans Crisis Line increases during the 6 months immediately after the referral and contact with that system, and rates of repeated suicide behavior decrease, both within our system over time and after a referral for care or a rescue from the crisis line. So we were beginning to understand that engagement and points of contact and continued contact and meaningful contact resulted in changes in suicide risk among our veterans. But we knew it wasn't sufficient. So we continued seeking new information to contribute in any way we could to informing suicide prevention programs. In 2011, we partnered with the Centers for Disease Control once again and the Department of Defense to create something called the Joint Suicide Data Repository. The idea behind the Joint Suicide Data Repository was to share all information we had on veterans and suicide, including information collected from active duty service members and that collected from the Veterans Health Administration. In addition, we agreed that we would compile all of our information and partner with CDC to try to gain information on all deaths among veterans, regardless of their point of service or period of service. Our first effort was more than 25 million records submitted to the National Death Index for searching so we could obtain that information. It provided an invaluable source of new information that has been contributing since. We continue partnering with states and collecting more information, and at this time, we share some form of information with every state in the United States and 3 territories and possessions. That information is all contributed in very important ways. In 2014, we released an update to the Suicide Data Report that contained new important information. It showed the rates of suicide among those with mental health disorders had continued to decrease over the past 10 years. And the rates of mortality among those who survived a suicide attempt had decreased by more than 40% over the past decade. The programs and services and engagement with care was resulting in a difference in those outcomes for those populations. We also, for the first time, began to understand differences in suicide risk and rates among those who do and do not come to Veterans Health Administration for their care. And looking at one high-risk group identified by CDC, middle-aged adults between 35 and 64 years of age, we were able to demonstrate that rates of suicide among that group among civilians or members of the U.S. general population had increased by 27% over the past decade. Among those who come to VHA for care, they had decreased by more than 16%. But the differences were even more stark when you compared those who did and did not come to VA overall, veterans who did not come to VA overall. Among veterans who came to VHA for care over that time period, rates of suicide had decreased by over 30%, while increasing by over 60% among veterans outside of VA during that same time period. The information we gained from states and in collaboration with the Department of Defense and the Suicide Data Repository has continued to contribute in meaningful ways. We learned that over 70%, or approximately 70% of all suicides among veterans who engage in VHA services are the result of a firearm injury, and there's been very little change in that over the past decade. We learned that the percentage is even higher among some veterans who don't come to VA for care, and when we look at data for each state, we see regional differences in that, contributing partly to contextual factors or the characteristics of those states and in those areas. And we also learned a lot more about the differences over time among those who do not come to VA for care. Over the past decade, we've seen a growing disparity between those who come to VA for care and those who do not, where the relative risk or the difference between those two populations is highest in our last year that we're able to look at data in 2011. We also learned important differences about rates of suicide among women and men. We know that rates of suicide following separation from active duty military service among our most recent veterans, those who've served in Iraq and Afghanistan, decreased by about 40% within the first 5 to 7 years following separation from service, while among women they remained relatively constant over that time period, not showing that same difference. We know the rates of suicide by firearm are higher, well, the risk for suicide by firearm is higher among women than it is for men. All important opportunities for intervention and preventive services. We continue to try to make this information useful and informing it by directly informing suicide prevention programs and linking it with the activities of the clinicians who provide care within our system. We've also sought to make it broadly available to all VA researchers and DoD program officers and researchers who seek to use this information and contribute in any way that they can. At this time, more than 100 investigators and program officers across VA and DoD use information from the Suicide Data Repository in their research and in their program activities. One example of this work is the predictive analytics model, our model for predicting suicide risk that was developed by VA researchers in collaboration with the National Institutes for Mental Health and published last year. An important step in not just using information to describe suicide and evaluate the impact of suicide prevention activities, but to meaningfully contribute to the identification of those at risk so that early intervention activities can take place, perhaps even for primary prevention without waiting for some other detection of risk in another clinical or meaningful way. We continue with that effort by partnering with our academic partners, Dr. Ron Kessler, whom you'll hear from later today, and trying to find new ways to more efficiently analyze that information and looking at that information to understand different outcomes. We carry forward with our collaboration with CDC and DoD. This year, we've submitted more than 55 million records to the National Death Index to seek information on cause of death among anybody who served any time period and who's died from 1979 through 2014. CDC is actively processing that search now and returning the information to us, and we expect by June of this year, we will have that information available and be able to once again contribute to meaningful ways, this time with unprecedented information to inform our suicide prevention programs. The challenge of talking about data is always that it seems to be detached from our clinical activities. I want to stress to all of you that that is explicitly not the case for us. For us, data is simply a way to inform suicide prevention activities, to inform evaluation of programs, and to provide contribute to a way forward. Unfortunately for Mrs. McDougall, my handwriting never got better. Fortunately, I had Steve Jobs and Bill Gates to find a solution to that who would allow me to effectively communicate. In many of the same ways, much in the same way, we're using innovation to provide that bridge between an unknown or a need and our services. And we hope that all of these activities will inform action as we move forward. Thank you.
Good morning. First, I think that I was one of the people whose blood left my face when Dr. Shulkins talked about doing this within 1 month. But today it is absolutely back, because what an extraordinary group of people we have out here. Our need to collaborate with all of you and for you to collaborate with us couldn't be more important, especially with this issue. I graduated from grad school 10 years ago, and I wanted to work with extraordinary people. I wanted to work in a system of amazing patients, amazing staff, just an incredible group. So I applied to VAs. I didn't have many experience with veterans in my past or in my history. My grandfather was a Seabee who was out in Guam for a couple years, but other than that, it was really a very non-veteran focused family. But I knew that I wanted to see what it was like to work with veterans and to really better understand what resilience is like. I applied to 10 internship programs. I had lived up and down the East Coast between Rhode Island and Virginia, and I knew that I wanted to just try something different. So I moved out west. I applied to all 10 VAs from Denver to Honolulu, except for San Diego, because my ex-boyfriend had just moved there and I didn't want to see him at all. And I ended up matching at Denver, the Denver VA Medical Center. Within my first year of clinical work, I lost 3 veterans to suicide that I had worked with. And for a young PhD psychologist, first year out of her training, this blew me away. I didn't know what I should do next. I had thought that I was going to become this clinician and sit down and talk with people, but I knew that there was something bigger that I needed to do. I was so grateful that while I was there, the Denver VA's Mental Illness Research, Education, and Clinical Center was in its infancy, and their focus is on suicide prevention. While I was there, they started up a suicide prevention consultation service, so that for people at Denver, clinicians who are working with some of the most difficult patients, those who had multiple suicide attempts, we were able to get consults and really sit down, and it took at least a month to go through some of these assessments. And it then morphed into a call center, which I think is pretty much unheard of, that is across the VA, that is a suicide prevention consultation call center. And any clinician, mental health or any other clinician who is concerned about somebody who just can't get better potentially can call this call center that is based out of the Denver VA MyRec. It was then that I really understood how individual people are when they're feeling suicidal, and how important it is to really get to the crux of that individual person, and yet within a larger context. I then moved out to the University of Rochester to do another postdoc out of the Center for the Prevention of Suicide, and boy, was that an experience, because during my time there, the crisis line was stood up. And it just so happened that I was then living in Rochester. The crisis line is based in Canandaigua, New York, which is right on Lake Canandaigua, Finger Lakes, beautiful, Riesling. It's just really a lovely area. There were about 40 people on staff at that time at the crisis line, and I worked for 6 months on the crisis line thinking that it would really help to inform some of the research that I wanted to do, particularly with older veterans. And I'm so glad that we're talking not only about our youngest veterans, who we know are at high risk, and we know we just ache for them, but we can't forget our older veterans, our Vietnam veterans, our World War II veterans, our Korean War veterans, because, as has been said, of all veterans who die by suicide, 70% of them are 50 years old and older. And so we have to remember how, and we have to learn how to do some of our outreach and how to engage with those veterans, and we need your help in doing that. So please help us, and so that we can also figure out how to work with you with our older veterans as well as our youngest veterans. So I worked at the crisis line for 5 years. I oversaw all of the clinical work there at that time, and from the time that I started, it started with 40 people. We are now up to over 300 Veterans Crisis Line responders. These are some of the most extraordinary people you will ever meet. Many of them are veterans themselves. Most know veterans. Many are family members and friends of veterans. The thing that has, I think, been so exciting about it is that people are calling. People are using it. We have had, as you said, as has been said, over 2 million calls. But then as we are moving them to our local efforts, our suicide prevention coordinators, we also need to make sure that we're engaging them in care in a way that they can continue to get better. Many of the people that call the crisis line and most of our veterans that we know who end up dying by suicide have never been engaged in VA care, and we don't know what kind of care they've been engaged in before. So I think that it's just so important that we learn more about how to further engage our veterans. I'm here as a representative on stage, though there are some in the audience, of over 800 people at VA who work in suicide prevention, who work as suicide prevention coordinators, who work in the Veterans Crisis Line, who are researchers out of the VISN-19 MyRec and the Center of Excellence in Canandaigua. 800 people, that's all we do all day long, day in and day out. And so we have what's called the VA's integrated approach to suicide. We are the largest integrated medical system in the country, and with that we're able to have a very integrated approach to suicide prevention. For instance, in our enhanced care delivery system, there are many systems that have followed us in that we have a patient record flag system. So that if we know that a veteran is at high risk for suicide, and that may be because of a recent suicide attempt, it may be because they just have had more chronic thoughts of suicide, they are put on this high risk flag with their knowledge, so that if I, as a podiatrist, which I'm not, but if I was a podiatrist and I was opening up a veteran's record, there's going to be a pop-up that will say, this veteran is at high risk for suicide, so that I, Dr. Podiatrist, can say, you know, I'm looking at your feet right now. But I'm wondering how you're doing. How is everything else going right now? This is an unbelievable system to be able to have and make sure that, so that we can make sure that everybody is checking in with those who are at high risk for suicide. But what about those veterans who don't come to VA? How do we know? Even though I work for VA, and I've worked for VA for almost 10 years, and I'm very, very proud to work for the VA, as was said, less than half of all veterans use VA. But more and more veterans die by suicide than non-veterans. And I personally feel responsible for all 22 million veterans. And we at VA feel responsible for all 22 million veterans when it comes to suicide prevention. So with that, we have to work together, and we have to get out into the community. If you can get the next slide. So this is just a lot of words, but we've reached millions and millions of people with our PSAs, with our outreach efforts, with our local suicide prevention coordinators who go out into the field at least five times a month to try to engage all veterans and to try to teach them about what resources are available. Millions of people we have reached. What are we missing? And then at the same time, as you all are working within your organizations, what are you missing that we can fill gaps with? This is where this day is such an extraordinary beginning for us, a continuation in many ways because we do have a lot of relationships with other organizations, but this is what makes this such an important day. During our breaks, we're going to be showing a lot of the public service announcements. But just in conclusion, we're all in this together. I am very available as far as any effort in collaborating as part of the VA community and as part of the community in general. This is my passion. Besides my husband and my 3-year-old, this is what I do. And this has become such an integral part of my life. And I do it for our veterans, I do it for our caregivers, and I know that we're all sitting here thinking, that you all are a part of this too. And I'm just honored to have you be a part of my experience in really helping with this incredible issue. Thank you.
Thanks to you both. And I think it's important that you're asking questions rather than speaking to us. That is really refreshing. So thanks for that. I just had a couple thoughts as you were speaking, and one of them is just the preponderance of the percentage of older veterans who are taking their lives. And it's such a reminder to me as we focus so much oftentimes in the media and our own attention on the younger veterans, and that the older vets, like my dad, come from an era where mental health issues are shameful, where there's a huge stigma attached to that, and we don't talk about the war, and we don't talk about what happened, and you pull yourself up by your bootstraps. So the importance of taking the stigma and the shame away from this is so key. And I remember about a year after Bob was injured, and he was beginning to come back, and his words were coming together, and cognitively he was piecing things back together. I could finally let my breath out after a year, and I remember crashing, right? Because what goes up must come down. So I'd held everyone together, the 4 kids. I'd tried to make them believe that, Daddy was going to be okay, and then I crashed. And I remember thinking, well, what's wrong with me? Why can't I, every day could be Doris Day here. It used to be. Why can't I get my feet on the floor? And it was my mother, my 78-year-old mother, who said to me, Lee, you need body armor. You need mental body armor, and you need to go talk to somebody, and maybe you need to take medication, and none of that is anything that you've done wrong. Sometimes things in life are just simply bigger than you are, and you need to get help, and you need to tell yourself that it's not because you're weak. And so when we remind everybody out there who's suffering that these are issues we all have, look at me, anchor's wife, hot pink dress in Washington, not cool, right? Look like I have it all together. I didn't. I'm you. I'm that veteran's wife. I'm every woman. And so taking the stigma off this and starting to talk about things and asking the questions rather than telling us how it's going to go is what makes today so important. So thank you very much.